I'll introduce the second speaker of our session. My privilege to introduce Professor Benjamin Cowling. Professor Cowling has been the head of Division of Epidemiology and Biostatistics of Hong Kong U since 2013. He is also a co-director of the WHO Collaborating Center for Infectious Disease Epidemiology and Control at Hong Kong U School of Public Health. Professor Cowling's primary research focus is in infectious disease epidemiology. In recent years, he has designed and implemented large-field studies of influenza transmission in the community and the effectiveness and impact of control measures. His latest research has focused on the modes of respiratory virus transmission, influenza vaccination effectiveness, and immunity to infections at the individual and population level. So without further delay, Professor Cowling, please.
Thank you very much. I will share today some thoughts on COVID-19 epidemiology and control. And the second half of my talk will be focusing on vaccination as our pathway back to normal. Going back a couple of years now, I was involved with the World Health Organization project to look at what kind of public health measures could be used to mitigate transmission in the next flu pandemic. We looked at hand hygiene, face masks, school closures, working at home, travel restrictions, a lot of different things. I think about 20 different measures. We didn't include lockdowns. That was maybe considered too drastic 2 years ago. Now, I think we'd have to look at that as a measure to be considered in a future influenza pandemic. On the slide here is showing that the basic idea of flattening the curve for something like an influenza pandemic. So without any interventions, we might have something like shown in green, a very sharp peak with a lot of people that are sick at the same time. And if we could use some public health measures, social distancing, then maybe we can flatten it out, spread over a longer time. But one of the issues, and particularly an issue with COVID-19, is we have a limit on the healthcare system capacity. In Hong Kong, we have maybe 40,000 hospital beds, 1,000 something, maybe 2,000 intensive care beds. And it's really not enough to cope with a large COVID-19 epidemic. So we've seen the problems in India in the past weeks, and that situation can actually happen anywhere in the world. It nearly happened in the United Kingdom. It's happened in New York, in northern Italy a year ago. It could happen in Hong Kong. It could still happen in Hong Kong. So I think when we look back a year or so ago and think about all the public health measures that were put in place, the reason that we really try to stop COVID from spreading at all is not to flatten the curve, because as you can see on this slide, flattening the curve would still be catastrophic. Actually, the objective in Hong Kong has been to get the COVID case numbers to zero and keep them at zero, because the only alternative would be a large epidemic that ultimately overwhelms the healthcare system. And until that situation changes, which I think it could with vaccination, then we'll be in the same position of having to keep COVID-19 case numbers as low as possible. Now, there's often a concept that maybe flu and COVID are kind of similar, and if we just handled COVID like flu, then we'd probably be okay. But I could respond with this figure. If you look at the bottom of the graph, the tiny yellow humps are actually large flu seasons. The flu season in 2017 to 18, the second one, was actually one of the largest flu seasons in the United States on record, and is absolutely dwarfed by the impact of COVID-19 in the United States, despite a series of lockdowns, extreme social distancing, stay-at-home orders, and so on. And that's because of the severity of COVID-19, 10 to 20 times as severe as flu, and everybody susceptible to COVID-19, unlike flu. So why is COVID-19 so difficult to control? Firstly, it's more transmissible. It has a higher reproductive number than flu. For seasonal flu, reproductive numbers probably in the range 1.2, 1.3, maximum 1.5, meaning on average, one person will just infect 1.2, 1.3 other people. For COVID-19, the equivalent reproductive number is probably between 2 and 3, meaning one person on average will infect 2 to 3 others, unless we make an effort to stop that from happening. For flu, we have a lot of immunity in the population from previous infections and from vaccinations. For COVID-19, we don't have any population immunity. Even now in Hong Kong, we have almost no population immunity. Thirdly, while most infections are mild, a minority are more serious, requiring care in hospital, maybe even intensive care. And so when case numbers are relatively low, it's possible to deal with them. But once case numbers get higher and higher, it becomes a real challenge. And I think what we're going to see in India is that at the moment, mortality of COVID-19 is going to be 5% or more, where ordinarily it would be in the range of 1% to 2% case fatality rates. It will now be 5% because they've run out of oxygen, they've run out of capacity in the healthcare system to take care of patients. So that's a real problem. But then the fourth point, the mild nature of most infections is actually something that makes it very difficult to control. One of the major differences between 2003 SARS and SARS-2 now, COVID-19, is the severity profile of infections. With SARS in 2003, most infections were very serious, and that made them easy to identify, easy to isolate in hospital because you could identify them, and easy to control onwards transmission. The reproductive number was actually quite similar. It was between 2 and 3, but it's much easier to control when infections are largely severe, easy to identify the patients, easy to isolate them comparatively. Whereas with COVID-19, there's so many mild infections in the community that really can't be tracked down, can't be isolated, and then transmission can't be controlled. And then the last point, contagiousness is high around the time of symptom onset, even before symptom onset. So when we isolate cases, it's often too late. They've passed on infection already. Now in Hong Kong, I think we've been aiming to get down to 0. We've managed it after the second wave, managed it after the third wave. After the fourth wave, not quite, almost at 0, but there still seem to be some unlinked cases in the community in recent weeks. And what we found after the second wave and third wave is that it's difficult to stay at 0 cases. We'd like to, so we'd like to get down to 0 cases. We'd like to stay there. Taiwan's done a good job of that. Mainland China done a good job. Australia, New Zealand done a good job. Singapore, mostly. Hong Kong, we found it difficult to stay at 0. We now have quarantine on everybody coming into the city, but there are still loopholes. Those were resolved for a little while. So for example, aircrew had to quarantine as well. But some of those restrictions, some of those loopholes may be coming back. We're doing test and trace, which is working quite well to identify some infections, but not all. So I'll show in a moment the impact of some of the control measures that we're using in Hong Kong. We definitely need to do more than test and trace. We need the moderate social distancing. In my group at the University of Hong Kong, I've been tracking the reproductive number over time. And what we've seen is ups and downs as control measures are implemented and then as they're relaxed. The fourth wave has been successfully controlled with the reproductive number mostly below 1 since the beginning of December. So that's about 4 months now. But it hasn't ever reached as low a level as we got it after in the control phase of the second wave and in the control of the third wave. And I think one of the reasons for that is response fatigue, as I'll come to in a moment. While we've been very, very good at wearing face masks, the red estimates at the top of this slide from my population surveys, almost universal masking in the community, that hasn't been enough. So throughout the second, third, fourth wave, we've had very high use of face masks in the community. We've been doing testing and contact tracing with isolation of cases, quarantine of contacts. It's worked well, but it hasn't been enough. In order to suppress transmission, we've had to use this moderate social distancing measures to get reproductive number down below 1, which then means the case numbers are declining from week to week rather than increasing from week to week. And those measures have included some of the things listed on the slide, the reduction in mass gatherings and the bar and karaoke and leisure facility closures, I think, relatively more important. Now, I mentioned before, I think one of the reasons why we haven't done so well in the fourth wave is because of response fatigue. And that's shown in these data from my weekly surveys. Again, each of these data points is a survey of either 500 or 1,000 people in Hong Kong with random digit dialing. So we've done a lot of surveys in the past year. And the purple points with confidence intervals show the estimate of people saying they've been avoiding social gatherings. So that tracks risk. When there's more cases in the community, people do more social distancing. and the government recommends that, and there's a little bit more forceful as well, and has other government measures which encourage people and remind people to stay at home more often. But when we compare the third wave and the fourth wave, we see relatively less effort being made to do social distancing. And I think that's because of fatigue. I think people are a little bit tired of social distancing. What that means, though, is if we were to have a fifth wave, it might be even more difficult to get it under control, because we just barely got the fourth wave under control and it's dragged on for a long time. If we were to have a fifth wave with a more transmissible variant, then that would be an even bigger problem, and we might need some more drastic measures. Now, in the longer term, what's our way out of this? It should be vaccination. Until vaccines are available and used with high coverage, we'll still have the same problem that we've had for the past year. The surges in COVID-19 transmission would threaten to overwhelm our healthcare system. The potential number of deaths is extremely large if a large epidemic were to occur. And while we look at India and think that kind of thing would never happen here, we can also look back a year ago and look at what happened in New York. And actually, it was similar in some sense. Hospitals overflowing with patients, one ventilator having to be used for multiple patients, and doctors having to make life and death decisions based on patients' underlying conditions and age, and really difficult problems. So what can we do with vaccinations? In general, there are two types of mode of action for vaccines shown in this slide here. So I've got here on the left, a healthy person; in the middle, a person with maybe a milder illness so they can still stand up; and on the right-hand side, someone who's very sick and in hospital. And so some vaccines can reduce the risk of an infection occurring to start with, and that's blocking the pathway from a healthy person to someone who's sick but still standing up, still standing. A lot of vaccines work in that way. They generate a lot of antibodies which protect the person from even being infected in the first place. There's some other vaccines, I think rotavirus may be a good example, where the vaccine doesn't necessarily protect against infection, but it does stop the disease if it occurs, or the infection if it occurs. It stops it from progressing to be more serious. And so that's good if we want to protect people against the serious form of a disease, but it won't necessarily limit transmission. Vaccines that prevent infection will limit transmission because some people are not getting infected anymore. Vaccines that prevent severe disease maybe can have an effect on transmission if they're also limiting viral shedding, if they're limiting contagiousness, but it's not so clear how much of that will go on. So what have we got in Hong Kong? At the moment, we've got availability of the BioNTech vaccine and the CoronaVac, the Sinovac vaccine. Both vaccines are almost 100% effective against severe or fatal infections, at least in middle-aged adults. We don't know about the Sinovac vaccine's efficacy or effectiveness in older adults, but we suspect it should be good. On the other hand, though, when we look at effectiveness against mild infections, the BioNTech vaccine is clearly superior. We've heard estimates of above 90%, maybe 95% or more against mild infections, compared to something like 50, 60% for the Sinovac vaccine. The randomized trial, which is the best quality evidence, I think, from Brazil, was 50-point-something percent, 50.8%, I think. So I've given some star ratings, which I know could be a little bit controversial in terms of how well the two vaccines work in limiting infections or limiting severe disease. And on the right, I would say that both vaccines are 5-star against disease. So that's great for the people that get those vaccines. And then on the left-hand side, the BioNTech vaccine is a little bit better at preventing infections. I would say 5-star compared to maybe just 3 stars for the Sinovac vaccine, which is not as good at limiting infections. Maybe okay at preventing transmission. We don't know yet. We don't have a lot of data. My suspicion is not as good, though, at preventing transmission. So what can we do with these vaccines? What's our way back to normal? I'm going to give 2 options, 2 possible strategies. The first one is a disease-limiting strategy. So if we acknowledge that COVID-19 could continue to spread in the future, what we'd like to do is give everybody the COVID-19 vaccine. If we don't manage to give the vaccine to everybody, then people who haven't got the vaccine would still be at risk of severe COVID. People who do get the vaccine, though, would be at much lower risk of severe COVID. That's not to say there wouldn't still be hospitalizations, and even deaths in a vaccinated population. There would be some, but there wouldn't be nearly as many. And most likely this strategy, the disease limiting strategy of vaccinating almost everybody, would allow us to get back to normal. And when COVID was spreading in the community, we would likely have a controllable, a manageable number of infections, a manageable number of hospitalizations, and hopefully not so many deaths, maybe something comparable to flu season. So maybe hundreds of deaths per year, but not thousands or tens of thousands. We do have to be aware, though, that if we choose this strategy, we'll have to continue to shield people who are vulnerable, people in whom the vaccines don't work so well. And I would count older adults in that group, because we know even the BioNTech vaccine does not work as well in older adults as it does in younger adults. Estimates from Israel are something like effectiveness of 80%, in the 80% range for severe disease, not 100%, 80-something%. So that means there will still be older people, even who get the BioNTech vaccine, even, I guess, who get the BioNTech, the Sinovac vaccine. There will still be older adults, fully vaccinated, who get very sick from COVID if they're exposed to infection. So to summarize this strategy, the objective would have to be almost 100% vaccine coverage, and then we would still have COVID circulating potentially. We'd still have hospitalizations, we'd still have deaths, but at a much lower number than if we were not having population vaccination. And in order to achieve this strategy, we can use whichever vaccines. We can use BioNTech, we can use Sinovac. The important thing is to get everybody vaccinated. The second strategy is another concept called herd immunity, where if we can vaccinate at least enough people that infections can't spread, then we don't need to vaccinate everybody. We just need to get a high enough coverage that there's enough immunity in the population. Even if infected people were to come into the city, the infections wouldn't really be able to spread. In the figure on the right-hand side of this slide, there's a transmission from one person to a second person, but that's it. It's just a small cluster. And you could imagine if there were pockets of vulnerability in the community, pockets of unvaccinated people, there could still be outbreaks, but wouldn't be any large community transmission. How can we get to herd immunity? We'd have to get a level of population immunity, probably around 67% or higher. And that's based on the simple calculation with a formula shown on this slide. The reproductive number is probably around 3 in Hong Kong, with a high density in a population. And so to get 67% immunity, that doesn't mean 67% vaccine coverage. That means 67% population immunity. That's tough. That's a high level of immunity that's required through vaccination. The advantage is that it protects even people who are not vaccinated, or even people in whom the vaccine doesn't work as well, like older adults. Now, to get 67% population immunity, we'd probably need at least 70% of the population to be vaccinated if we were just using BioNTech, because 70% times the 95% effective of BioNTech, 95% effectiveness, 0.7 times 0.95 is about 0.67. If we use quite a bit of Sinovac, it's going to be difficult to get up to that level of population immunity because of the lower effectiveness of the Sinovac vaccine. And so it would turn into maybe the other strategy of just giving vaccination to everybody. So I think there's essentially two choices in terms of how a population uses vaccines. The first one was whatever vaccine you have, give it to as many people, ideally everybody. The second strategy, aim for herd immunity with at least 70% coverage of a highly effective vaccine. It seems to me that in Hong Kong, we're heading more towards the first strategy than the second strategy, which means ultimately the government would have to find a way to get up to almost universal vaccination. And remember that younger children can't be vaccinated right now. Most likely 12 to 16s will be able to receive the BioNTech later this year, but younger children, I'm not sure. Now, the problem for Hong Kong is the low intention to receive vaccination. This is, again, data from my telephone surveys, where there was a lot of enthusiasm months ago before Christmas in 2020, and that's kind of been up and down, but it's dropped particularly since early March. And currently, if I was to project just on the basis of responses in my telephone survey and knowing how many people have already got vaccinated, if I was to project today, if nothing else changes, how many people will eventually get vaccinated, it's in the range of 40 to 50%. So it's far below what we need for either strategy. Remember, the first strategy, we need everybody. The second strategy, we need at least 70%, preferably mostly with BioNTech. So something has to change. Otherwise, we're going to be stuck. And when we look at the age-specific intention, there's a lot of respondents in my surveys, shown in red here, who say they will never get vaccinated. That's 20% of people. So if we were aiming for herd immunity, we could try and get everybody who's not red, everybody who's not saying never, try and incentivize them and persuade them to get vaccinated and at least get up to herd immunity. But if our objective in Hong Kong is for everybody to get vaccinated because it won't be safe until we do that, that's going to be a real challenge to get people who respond that they'll never be vaccinated to be vaccinated. And I don't know how to overcome that. The problem is often not that a lot of people in Hong Kong don't want to get vaccinated. As I showed on the previous slide, it's 20% that say never, but a lot of people are hesitant. They say they want to wait and see what happens, wait and see if there are any side effects being reported, or maybe just wait for some other incentives like the travel bubble we heard about today, or maybe some other incentives or special deals for people who are vaccinated. So there is still an opportunity to at least get to a higher level of vaccine coverage if the hesitant people can be persuaded to receive vaccination. Now, on to my last two slides, this one and then one more. I published an opinion piece in Ming Pao and then later something similar in Citizen News in English, where I talked about three possible strategies for the next year, 2 years in Hong Kong. One of them is kind of what we've been doing already, suppress and lift, meaning that when case numbers are high, we need a lot of social distancing measures to bring the case numbers back down to a low level. And then when they get to a low level, those measures are relaxed. And so eventually that process will lead to herd immunity. But in Hong Kong, it would take a long time. So far, less than 1% of people in Hong Kong have immunity through infection. Now we have 10% or so people receive their first dose of vaccine, 5% fully vaccinated. We're going to take a long time to get to herd immunity with the status quo. A second strategy is a variation where we aim for 0 cases and really try hard to stay at 0. We haven't done it so well in the past. Taiwan, Australia, New Zealand, and mainland China would be models for this approach, which I think is a pathway for Hong Kong. And that way would definitely not lead to herd immunity. If we're aiming for 0 cases, we're not even, ideally we'd have no population immunity building up from infections, only whatever we get from vaccinations. And then the third one is the possibility we could go back to normal if we get high vaccination coverage, either the first way with almost everybody vaccinated with any vaccine, or B, herd immunity with high coverage of a highly effective vaccine. And so if I could conclude by saying that COVID-19 still poses a major threat to us in Hong Kong. It has done for the past year, it still does now. If we don't believe the threat, just based on what's happened in India, we can also look back at what happened in northern Italy, what happened in New York a year ago. Those are examples of what could befall us in Hong Kong if we drop our guard now after doing so well for a year. Mass vaccination can allow us to return to normal. We wouldn't need to worry about COVID anymore. We wouldn't need the quarantines, the social distancing, the face masks, but it's going to need a high coverage of vaccines. And that's going to be a challenge because of hesitancy. One of the factors feeding into hesitancy is maybe because we've been so successful in the past year, maybe there's low perceived risk of COVID. And so when there's not a lot of benefit to vaccination in terms of preventing a risk that isn't apparent because we don't have a lot of COVID around, at the same time, no other incentives to get vaccinated, like a relaxation of social distancing, mask wearing, quarantines, and so on, then I can understand why a lot of people are reluctant to get vaccinated. And I think that's something which really needs to be addressed quite urgently. Having said that, if the mainland is following the same kind of path as Hong Kong and not getting high vaccine coverage for another year or even longer, then it's possible that for Hong Kong, a strategy would be to go for local elimination. We've heard the officials in Hong Kong talking repeatedly about how Hong Kong could have a travel bubble with the mainland if we can get to a low daily case number, no unlinked cases, small numbers of linked cases, then we could have free travel without quarantine backwards and forwards to the mainland. And that may be an attractive solution even for 1 or 2 or 3 years in Hong Kong until vaccine coverage gets to a higher level for whatever reason. That may be a plausible, conceivable medium-term strategy. I think when we look at other places in Asia, most likely they're going to return to normal in terms of relaxing quarantines, relaxing social distancing measures after they have high vaccine coverage. In Hong Kong, we might even wait a little bit longer, even after getting a higher vaccine coverage, depending on what happens in the mainland. And I think with that, I will finish and ready for the roundtable.
Thank you very much, Professor Cowling. So vaccination is a very hot topic, and also we have a couple of questions related to vaccination and also to Grace's previous talk. So first of all, thank you both very much. Thanks a lot. Learned a lot.